Λοιπόν, καλησπέρα και από αυτή τη θέση, αγαπητοί συνάδελφοι. I feel extremely glad, in fact I feel privileged to present Professor Richard Light, a living legend of modern medicine, to give a talk for us this evening. And I think that it makes sense, the founder of clinical science of pleural disease to be the most appropriate person worldwide to talk to us about the future of pleural disease. Rich.
Let's see now, how do I work this?
Don't worry, there will be no time limit.
No. Well, before my slides are up, I would like to thank the organizing committee of the Hellenic Society for inviting me to Greece. My wife and I have been to Greece, I think, 13 times, and we've had a wonderful time each time, except for the last time, and I will tell you about that in a minute. Okay.
This is backward, and this is a pointer.
Okay, so this is forward.
This is the big green one is forward.
Is what?
The big green one is forward.
Okay, the big green one. The last time I was in Greece, I was staying at the Hilton Hotel, and I was tired of paying too much money for the Diet Cokes. So I walked across the street, and on the way back, I got hit by a bicycle going the wrong way. And the first thing I knew, I was covered with blood in the ambulance, not knowing where I was. So I hope that does not happen again. Okay, the future of pleural disease. Pleural disease research. I think it is interesting that pleural disease research will continue to increase. This is a compilation by Bielsa and Porcel, and they found that the number of pleural disease papers increased from 100 in 1965 to 550 in 2015. The highest number of papers were from the United States, and this surprised me. Japan and Europe also publish a high number of papers. And in the future, I think there will be a higher percentage of papers from China, Korea, and Turkey. Now, how about transgenitive effusions and exudative effusions? As I'm sure you all know, a transgenitive effusion occurs when the systemic factors influencing the formation of pleural fluid are altered such that pleural fluid accumulates. The fluid may originate in the lung, the pleura, or the peritoneal cavity. In contrast, an exudative pleural effusion occurs when the local factors influencing the accumulation of pleural fluid are altered such that a pleural effusion develops. Most common cause is increased capillary permeability in the lung, leading to increased interstitial fluid. Other mechanisms for exudative pleural effusions include obstruction of the lymphatics in the pleura and increased capillary permeability of the pleura or of structures in the peritoneal cavity. Now, why separate transgenates from exudates? Well, if a patient has a transgenitive pleural effusion, usually due to heart failure or cirrhosis, then you treat the heart failure or cirrhosis. Alternatively, if a patient has an exudative effusion, more investigation is indicated to determine what the local problem is that is causing the pleural effusion. Now, you know what this is. One of these is a panda and one is my wife. Can you guess which is which? Why do I show the picture? Well, sometimes it's a bear to tell whether you have a transudate or an exudate. Separating transgenates and exudates. For some reason, I like Light's criteria. I don't know why I like Light's criteria, but I do. And according to Light's criteria, an exudate meets one or more of the following criteria while a transudate meets none. The pleural fluid divided by the serum protein greater than 0.5, you have an exudative pleural effusion. And the pleural fluid divided by the serum LDH greater than 0.6, you have an exudative pleural effusion. The pleural fluid LDH is more than 2/3 of the upper normal limit for serum, you have an exudative pleural effusion. Now note that this paper was published in 1972. That's before a lot of you people were born, I think. And if somebody would have told me in 1972 that I'd be famous for this paper, I would have told them they were crazy. Of all the research I ever did, this was the simplest, but it made me the most famous. And the moral of the story is it's much better to be lucky than to be smart. Now, do we need biochemical tests? Some people think you can look at the patient and say whether they have a transudate or an exudate without any tests on the pleural fluid. And this was a study from Spain, and they took 249 patients with undiagnosed pleural effusions, and 2 pulmonary physicians classified the effusion as probable transudate or exudate just before thoracentesis. They ended up with 185 exudates and 64 transudates. Clinically, they were correct with almost all the exudates. Have a young person comes in with a temp of 103 and pleural chest pain, they're having exudative pleural effusion. My criteria were very, very good at identifying the exudates, but transudates, they were wrong almost half the time clinically, and 25% of the time when they use Light's criteria. So how do we identify true transudates when exudative criteria are met? 2 proposed tests, both involve the gradient or the serum value minus the pleural fluid value. And the 2 gradients you can look at are the protein gradient. If this is more than 3.1, you in all probability have a transudative pleural effusion. The albumin gradient is more than 1.2, you have a transudative pleural effusion. And if you go down on the slide, no, that doesn't work. Okay, how do I go backwards now?
You want to go back?
No, I'm there now, right? Okay, forward. Where's the pointer? Is it the red thing here?
This one is.
Okay. Okay.
Go back.
Okay. So you can see with the protein gradient and with the albumin gradient, a higher number of transudates were identified correctly, but more exudates were misidentified. So my predictions in the year 2018, I think we will continue to initially use Light's criteria to determine if a transudate or an exudate. It's been good for 40 years, so why shouldn't we keep using it? And I just did that backwards. I want to go back.
This is the back. And
No, that's not. That went forward. Okay, predictions. Forward now. Okay. Okay.
This is the pointer. This one.
That's the pointer. Okay. Maybe I'll get this straightened out. It seems like every one of these is different. And as I get older, I have more and more difficulty using them. So my predictions in 2018, I think we should still use Light's criteria to initially separate transudates from exudates. I think we use N-terminal BMP to identify effusions due to heart failure. I think we may find a replacement for Light's criteria, but they've been trying to do that for a long time, so far unsuccessfully. Now, if the patient clinically should have a transudative effusion, but Light's criteria are met by a small margin, say the protein ratio is between 0.5 and 0.65, the LDH ratio is between 0.6 and 0.9, LDH is between 2/3 of the upper normal limit for serum, then I will look at the gradient between the serum and the pleural fluid protein. If the gradient is above 3.1, that means you probably have a transudative pleural effusion. The reason I use the protein gradient rather than the albumin gradient is we have the protein gradient when we get Light's criteria. What diseases cause pleural effusions? These are my best guesses in the United States. The two most common causes of transgenitive pleural effusions are congestive heart failure and cirrhosis. Most common causes of exudative pleural effusions are pneumonia, malignant disease, pulmonary embolism, viral illness, and post-CABG. This is a waterfall from China. And I should mention that my wife takes all these pictures, except with her and the panda. And we have a great time seeing the world. But this was a waterfall in Guangzhou, and I think when we have heart failure, the water can just pour into the pleural space. So BMP and N-terminal pro-BMP, the biologically active pro-brain natriuretic peptide BMP and the larger amino-terminal part, N-terminal pro-BMP, are released in equimolar amounts in the circulation when the cardiac ventricles are subjected to increased pressure or volume loads. The N-terminal pro-brain natriuretic peptide, NT-pro-BMP. This is the first article on it written by Purcell. And you can see that with congestive heart failure, it's much, much higher than with anything else, including the other transudate cirrhosis. And they concluded that an NT-proBNP above 1500 was diagnostic of congestive heart failure. It's interesting that the serum values closely correlate with the pleural fluid values. And this shows a slide of the serum NT-proBNP and the pleural fluid. I mean, that's a pretty good relationship. And also, if you notice, if you come up at 1,000 and go over here, it's 1,000. So it's a line of identity. And this is the only thing I know that has the same levels in both the pleural fluid and the serum. And maybe one of you people here will figure out someday why that is. But I don't know why it is. This shows the pleural fluid N-terminal pro-BNP versus the pleural fluid BNP. And we use the BNP for the most part at Vanderbilt. The N-terminal pro-BNP is certainly much superior to the BNP. And you can see there's not a close relationship. Note also that with the pro-BNP, if you're at 1,000, you're only at a level about 50 with the BNP. And so I don't use the BNP to diagnose the heart failure at all. Comparison the N-terminal BNP with the pleural fluid gradients for albumin and protein. 20 patients with congestive heart failure whose pleural fluid met exudative criteria by my criteria and were thought to have heart failure. They measured the N-terminal pro-BNP and the pleural fluid gradients for albumin and protein. 18 of 20 had N-terminal pro-BNP above 1,300. 16 to 20 had N-terminal pro-BNP above 1,500. 14 to 20 had BNP above 115. A BNP to me of 115 is not very impressive. And half of them had protein gradients above 3.1. So I sure think that the N-terminal pro-BNP is a good measure on pleural fluid to establish the diagnosis of heart failure. Now, there's the future for BNP and N-terminal pro-BNP. Can you use the levels of BNP in the serum or the pleural fluid to establish the diagnosis of heart failure? Certainly, you cannot use the levels of BNP as opposed to N-terminal pro-BNP to establish the diagnosis of heart failure in the pleural fluid. The levels of BNP are much lower and are not closely associated with levels of N-terminal pro-BNP. N-terminal pro-BNP is much superior to the BNP. N-terminal pro-BNP is better than the protein gradient in borderline exudates. I ask you again, why are the levels in the serum and the pleural fluid so closely correlated? And with treatment, do the levels in the pleural fluid and the serum decrease at the same time? No one knows. You could study that. What are the pleural fluid BNP levels when the patient has congestive heart failure plus another disease? This has never been studied, but I think the BNP levels would be high from the heart failure in this situation. Pleural fluid ADA, You guys measure the ADA and grease all the time? You never measure the ADA. Some people do, some people don't. I'm a big believer in the ADA. ADA, there's two isoenzymes. There's the ADA1, which is produced by the lymphocytes and the monocytes. There's the ADA2 produced only by the monocytes, and it is the one that's elevated with TB. And I think it's interesting, if you look at a tuberculous pleural fluid, it has all lymphocytes. But it's the monocytes that make the ADA2, which is elevated with tuberculosis. Patients with TB almost always have levels above 40. High levels are also seen with empyema and rheumatoid pleuritis. The specificity of the ADA is increased if it's combined with the pleural fluid lymphocyte poly ratio greater than 3. And non-tuberculous lymphocytic effusions usually have levels less than 40. In one study, only 10 of 506 patients with lymphocytic pleural effusions had elevated ADA levels. Okay, this is a cute little monkey from Tanzania, and the baby's looking up at his mother and says, "I don't know what this patient has. What do you think we should do?" Needle biopsy of the pleura. We used to do a lot of needle biopsies of the pleura, and blind needle biopsy of the pleura was the most common way to diagnose TB pleuritis over the past 60 years. However, I would maintain it's easier to diagnose TB with pleural fluid tests such as the ADA at the present time. You can also diagnose pleural malignancy with a needle biopsy of the pleura, blind needle biopsy of the pleura, but it's inferior to cytology. Rarely, in my opinion, is needle biopsy indicated where thoracoscopy is readily available. Now, I think in the future we will do more image-guided pleural biopsies. If the pleura is thickened or contains nodules, one good way to get tissue is with a CT or ultrasound-guided needle biopsy. It's less invasive than thoracoscopy, but you cannot do a procedure to produce a pleurodesis. In one study from Turkey of 170 patients with cytologically negative suspected malignant pleural effusions, they randomized the patients to CT scan with cutting needle or medical thoracoscopy. The CT-guided cutting needle made the diagnosis in 87% with TB or pleural malignancy. The medical thoracoscopy made the diagnosis in 86%. So they're about the same. And if I had an undiagnosed pleural effusion, I think I'd rather have a little needle go in my chest than have a big tube go into my chest and have people look around. But it's certainly something to consider. I think thoracoscopy will remain a mainstay for the diagnosis of pleural disease. This is different than it was 30 years ago when hardly anybody, at least in the Americas, did thoracoscopy. Thoracoscopy is very efficient at establishing the diagnosis of malignancy, including mesothelioma. It's also very good at establishing the diagnosis of tuberculosis. However, I think it's important to emphasize rarely does thoracoscopy establish the diagnosis of other benign causes of pleural effusion. I think when you do a thoracoscopy for an undiagnosed pleural effusion, you should do a procedure to create a pleurodesis, such as pleural abrasion and ejection of a tetracycline derivative or 2% silver nitrate. Okay, this is another scene from China, and it was cold. And I think most of us think when it's cold and snowy, we're likely to get pneumonia and a pleural effusion. So let's talk about pneumonia and pleural effusions for a few minutes. Pneumonic effusions and empyema, the future. I think it is likely that in the future we will culture pleural tissue rather than pleural fluid to identify the organism responsible for the pneumonic effusion. It's analogous to TB pleuritis. I think Gary Lee from Australia has shown that the yields with tissue biopsy, the culturing it, are much higher. I think we will use more sophisticated methods such as PCR will be used to identify the organisms responsible. And I think viral infections will be demonstrated to be responsible for many effusions that are presently called idiopathic. Myth 2, how do we treat the complicated pneumonic effusions? For a long time we used fibrinolytics and chest tubes and so forth. And then when this tube was published a few years ago, I think it's changed the approach to patients that have complicated pneumonic effusions. And MIS2, as I'm sure most of you know, was a multicenter, double-blind, randomized study of 200 patients comparing TPA 10 milligrams, DNase 5 milligrams, TPA 10 milligrams plus DNase 5 milligrams, and saline. Each was given twice a day for 3 days, and the primary endpoint was a reduction of absolute abnormality on the hemithorax between days 1 and 7. So if you had 50% of your hemithorax occupied by pleural fluid on day 1 and 25% on day 7, you got a score of plus 25. And you can see the scores here. Certainly the TPA plus the DNase was significantly better than anything else. And note also that if you look at the TPA alone versus saline, they're identical. The fibrinolytic does not do much by itself. And if you look at the data on the fibrinolytics, where the articles have said they're great, it's because they produce a lot of fluid. And if you put a fibrinolytic in any patient with a pleural effusion, you get more pleural fluid production. Also, in the combination group, the hospital stay was shorter, and there were a higher number of DNA patients who required surgery. So I believe that the use of a combination of fibrinolytic, TPA, and DNase will become more widespread and will result in less surgery. There's a relatively recent study of 107 patients from 8 centers treated with the combination. 84% received the drugs more than 24 hours after failing to respond to antibiotics and tube thoracostomy. The pleural opacity cleared from 35% to 14% within 72 hours. 92.3% did not require surgery. No deaths from pleural infection. I think the advent of TPA and DNase combination has decreased the necessity for surgery for complicated pneumonic effusions dramatically. Now, there are some questions about TPAs and DNase. Can the two compounds be mixed, or do they need to be administered individually? Now, do you use them in Greece? Do you use TPA and DNase in Greece?
We use TPA.
But not DNase. And why don't you use DNase? What? Because what? You don't believe it. You don't believe this study. Well, I'll tell you, I've treated a lot of patients now with the combination. I'm a big believer. I've also treated a lot with fibrinolytics, and they don't work. And DNase is the same thing you use with Bolman's for cystic fibrosis. And when they did the original study, they used the two things separately. They would put one in, wait 45 minutes, put the other one in. This became very time-consuming. It's been shown now you can mix them together. You don't have to inject them individually. Do you need to give all 6 doses? Probably not, but this has not been studied. If your chest x-ray clears after 3 doses, there's no use wasting the money on the other 3 doses. Can you give the compounds once a day? Yes, there's one study I have referenced here where they do that. Can you give the compounds for more than 3 days? Yes, there's another study that says you can. What are the optimal doses for TPA and DNase? Nobody has any idea. They pulled the doses they use out of a hat. And whether you could get the same effects with half the dose or a better effect with a higher dose, nobody knows. And interestingly, the mechanism for the effectiveness of DNase needs to be defined. In general, people think that it liquefies the pus. But some of the times when people have complicated pneumonic effusions, their pus is not thick. It doesn't need liquefied. But nevertheless, including the DNase with the TPA makes a big difference. Okay, pleural effusion secondary malignancy. Most common cause of subacute or chronic exudative effusion in the geriatric patient. The pleural effusion indicates systemic dissemination. You cannot cure it with surgery. Bad prognosis, median survival is 90 to 120 days. I think you should treat the effusion only if the patient is dyspneic and only if the dyspnea is relieved by the therapeutic thoracentesis. The only person bothered by the pleural effusion is the radiologist. Put the chest tube in the radiologist. He has a lot longer to live than the patient with the tumor. If the patient is not dyspneic, I recommend no treatment. This is a picture of two iguanas in the Galapagos, and my wife has named this Iguana U, and I think I have to iguana the patients, be nice to them when we're taking care of them. Philosophy of treatment. I realize the life expectancy of the patient is limited. Surgery cannot cure the patient because the pleural effusion indicates that the malignancy is disseminated. The main symptom from the pleural effusion per se is dyspnea. My goal is to alleviate the dyspnea via methods that require the shortest or no hospitalization and cause the patient the least distress. Two primary treatment options are the implantation of indwelling catheter or pleurodesis. Indwelling pleural catheter, the one I use the most is the Pleurex. It's a 16.5 French silicone rubber catheter, 66 centimeters long. One-way valve on the end of the Pleurex allows drainage when you hook it up to a tube. You usually drain intermittently via vacuum bottles. This is the tube. This is the vacuum bottles. And one of the problems with the indwelling catheter is when you use these vacuum bottles, they're very expensive. And I think we need to come up with a much better way to drain the malignant pleural effusions with these. First large series from Tremblay, retrospective analysis of 250 tunnel pleural insertions in 223 patients at a single center in Calgary, Canada. 4.4% failed insertion. Symptom control complete and 39%, partial in another 50%. No further procedure was necessary and 90% with the successful insertions. And they concluded that the tunnel pleural catheter should be the treatment of choice in malignant pleural effusions. Second large series from the United States, from Rush, inserted 295 catheters in 263 patients at Rush Medical Center. Unsuccessful in 10, no fluid. 58% of the catheters were removed after a mean of 29.4 days. Only 5 of the 127 patients who had their catheters removed required another procedure for the management of their pleural effusions. Pleurodesis with the indwelling pleural catheter. Spontaneous pleurodesis occurs in approximately 50% of patients at a median of 25 days post-catheter insertion. Presently, studies are underway in which the sclerostin is injected through the Pleurex. The big advantage to me of the indwelling catheter is that the entire pleurodesis procedure can be done as an outpatient. And if you only have 90 days to live, I just assume not spend 5 days in the hospital. The future of the indwelling catheters, I think the indwelling catheter will be increasingly used throughout the world for symptomatic pleural effusion. It can be inserted as an outpatient. Its insertion is associated with minimal complications, controls the symptoms of the effusion for the patient's life in about 90% of the patients. Patients who receive the Pleurex catheter have less total days in the hospital and less days in the hospital related to the pleural effusion than the patients who receive pleurodesis. However, it's important to take time to teach the family how to manage the Pleurex catheter. Questions about the indwelling catheter? How often should they be drained? The original studies, they drained them every other day. There's a recent study where they drain them every day and the number of spontaneous pleurodesis is high. In Australia, they only drain them when the patient gets short of breath. Have a lot less bottles used if you only use it there. So I don't know which is the best. Is there a less expensive alternative to the drainage bottles? I think there should be. What is the optimal treatment if the infusion becomes infected? I think most people now will leave the catheter in and treat with parenteral antibiotics. You don't need to take the catheter out. It can act as your chest tube. Will there be more spontaneous pleurodesis if the catheter is impregnated with a sclerosant such as silver nitrate? There's a preliminary study from the UK, Maskell, that showed like 8 out of 10 had a pleurodesis, spontaneous pleurodesis within a week. A big study has just been completed, and I'm not privy to the results of that study. And can the combination of the indwelling catheter and the injection of a pleurodesing agent decrease the time until you can take the catheter out? Pleurodesis, not going to spend a lot of time on pleurodesis because the thing's flashing at me. Agents for pleurodesis, I think the 2 best agents probably are silver nitrate and betadine. Doxycycline is very painful. Talc, I think, causes the ARDS. Pleurodesis with talc, it's the most popular agent for producing pleurodesis at the present time. It's perceived to be effective and the cost is minimal. Talc preparations are quite inhomogeneous. Big problem, intrapleural talc can lead to the acute respiratory distress syndrome, fatal in 1 or 2%. Talc disseminated throughout the body in these patients. No such problems with bleomycin or tetracycline. The future of pleurodesis, I predict that talc will be used less frequently in the future. I still worry about the induction of ARDS with talc. And remember, talc is just dirt. Can't we do better than that? Large CALGB study, biggest study ever, randomized study on pleurodesis. 486 patients randomized to receive talc slurry or talc insufflation. Only 60% were alive at 30 days without a recurrence. So 18% who were alive had a recurrence at 30 days. And 11 or 2.5% of the patients died from ARDS or respiratory failure in the week or so after they got the talc. This shows the time to recurrence of the malignant pleural effusion. And you hear 90% effectiveness quoted all the time about talc. But does this look like 90% effectiveness with 486 patients? Oh, darn it. The red one, right? The green one. I need to go back, darn it. There we go, okay, I didn't push it hard enough. Okay, here's talc slurry, here's talc insufflation. They're basically the same. You don't have to do thoracoscopy if you want to do pleurodesis with talc. But note also that if you come over to 100 days, you got 50% recurrence of your pleural effusion. That's a lot of recurrence. Nobody talks about that very much. Future of pleurodesis, so I think talc will be used less frequently. Remember, talc is just dirt. I think an agent that is better than talc at producing a pleurodesis will become available. We have shown that the intrapleural injection of TGF-beta produces better pleurodesis than does talc or doxycycline. We can't get any pharmaceutical company to support us on a study using TGF-beta. But I think something similar will come around in the future. Treatment of malignant pleural effusion is a future. I think systemic anti-tumor therapy will improve such that the treatment of the fusion is not necessary in some cases. I think intrapleural chemotherapy may prove to be useful. I think therapies will be developed which will decrease pleural fluid formation. And there's this one study from Athens by my chairman here and his co-workers where they showed this cis-methylnyl, whatever the heck that is, significantly reduced the formation of malignant pleural effusion. And I think in an adenocarcinoma model in mouse, there's several other possibilities, but none have been tried for humans. I really think this is the future. And I think I will stop on that. Now, the reason I'm back in Greece is that I love your country, and I love the people here. And Giannis and his wife, and me and my wife were on Peloponnesus, I guess about 12 years ago, and we had a wonderful meal of lamb chops and wine. And just as we were finishing, the orange fell on the table. And I thought this was a sign I should keep coming back to Greece. Thank you very much.
As you see, you are keep going back to Greece.
And we're going back to Peloponnesus on
Of course.
tomorrow.
To meet the orange trees. So thank you very much for your excellent talk.